This is a video demonstrating the surgical repair of a meningocele and CSF leak on the right side of the nasal cavity stemming from the cribriform plate. We'll begin the surgery by doing a basic sinus exposure, initiating uncinectomy and a wide maxillary enterostomy. Needless to say, in all such patients, a thorough exposure of the entire base of skull, the lamina papyracea and the septum is very important in defining the skull base defect, the size of it, and most importantly, the repair, which requires a lot of bare bone around the defect area. We can see here that there is a high deviated nasal septum is present. Sometimes that can also necessitate surgical correction. In this patient, we chose to avoid it because eventually the defect being in the cribriform plate, we will be requiring to excise the middle turbinate as well, which should give us the reasonable amount of space required for the access. This is using a microdebridor to create a reasonable amount of enterostomy, not too big. This is not a diseased sinus, so we just need to make wide openings of all sinuses. That is all, not to make them ultra wide. That is not the purpose. At all points of time, one must try to keep a clean surgical field. It matters a lot in improving the outcomes, the performance, and keeping your surgical times limited. The more the scope goes out and in, and the more the scope gets soiled, the more time you spend on hemostasis in the end always affects your surgical times. And obviously we do not want any hemostasis troubles towards the V end of surgery, the most important part when we actually conduct the repair. So once the enterostomy and the anterior ethmoidectomy has been done, we are now going past the basal lamella into the posterior ethmoids. As of now, the meningocele is not visible yet. It should be soon visible. So a generous removal of all the cells is very important to identify the skull base in its entirety, right from the frontal sinus to the sphenoidal plenum. We take off the portion of the superior turbinate as well, the inferior half. Most skull base leaks are a very good opportunity for a complete ethmoidal and paranasal sinus dissection. As the sinuses are clean, they are normally devoid of any disease, and one can proceed from cell to cell, dissecting the entire sinus framework. Once a basic ethmoidectomy and enterostomy has been completed and a sphenoidotomy has been done, we proceed to removing the middle turbinate. We excise it right from the attachment to the axilla while continuously pushing it down. One can now initiate seeing the meningocele, which is medial to the middle turbinate. Here we see it with its pulsations. This is the site of CSF leak. This middle-aged lady, 55 years of age, has already had 2 episodes of meningitis in the past 6 months, and this leak was identified on the endoscopy as well as the CT PNS and an MR cysternography. The leak is very well visible. The meningocele is very well visible towards the posterior part of the cribriform plate. So the posterior most part of this middle turbinate is where it is attached, can be either cut using a scissors, ablated, or here we use a simple straight through cut to crush the vascularity within it, the septal branch, the septal branch of the sphenopalatine artery. So it's always preferable to cut the middle turbinate in its entirety and not shed it because the mucosa over the middle turbinate is very valuable. One can use it to cover the skull base defect, whether in isolation or in conjunction with fat or fascia. So all attempts must be made to create clean cuts of the turbinate and to maintain the mucosal integrity as far as possible and avoid shedding of this vital tissue. So we see here, as the middle turbinate is removed, the space constantly increases. The deviated septum is not bothering us anymore. The ethmoidal cells still have some attachments at the base of skull which need to be taken down to create a flush wound amenable and conducive for repair. So as we can see, the meningocele is still visible, medial to the middle turbinate, slightly posteriorly on the cribriform plate, and we are just right now completing our ethmoidectomy and opening all the ethmoidal layer cells to identify the skull base. This is the sphenoid sinus on this side. The posterior ethmoidal cavity is open. One can see the ridges that define the location approximately of the posterior ethmoidal artery. We can see here the CSF leaking from this small meningocele. This is the sphenoid sinus. So the point is also the fact that when we are doing a repair on the cribriform plate, we must also open all sinuses reasonably widely so that our reconstruction, that is fat, fascia or mucosa, should not cover any unopened sinus or create a mucocele or sinus obstruction and sinusitis. So opening of the frontal sinus, the sphenoid sinus and the ethmoids widely is highly recommended and is very important to avoid any long-term complications. Now we are using a coablation. This is the ProSize Max plasma ablation wand from ArthroCare. So this is a wonderful tool for ablating the mucosa over the site of defect. So we can see here that some bit of the cartilage has been taken down, and we can see on the other side the mucosal flap is intact. This is a wonderful tool to achieve not only hemostasis but to also ablate the mucosa around the defect. As we see here that almost all sinuses have been opened, though not flush. So here we can use a combination of instruments such as straight and angle true cuts to remove the septations even more, and then use eventually the drill to take down further septations and to create flat surface for reconstruction. Now this surgery is done under navigation guidance. It is not compulsory, but it just adds one more tool, and sometimes post ablation or coagulation the CSF leak sometimes may become obscured, and finding the same may not be very easy, and just the presence of an intraoperative navigation adds a double layer of security towards the surgical outcomes. So once more septations have been taken down with the true cut, here we start using the coablation wand again to devitalize a reasonable amount of the mucosa around the defect that is just in front of us. We can see here that we use the irrigation on the coagulation wand to a maximum to keep our surgical field clean. We do not like charring here, nor do we like blocked wounds. We can see the meningocele layer here very clearly in front of us, and that is why a lot of bone around it needs to be bared and mucosa devascularized. Here we are using this wand on the coagulation mode, not the ablation mode. We do not want to ablate the meningocele. So we're using this on the coagulation mode just to achieve a lot of hemostasis as well as coagulate the mucosa on the meningocele and around it. This is the site of meningocele in front of us, but the wand was just in contact. Creating a bare bone and removing all possible mucosa around the defect is a fact that cannot be overstated. It defines the success of our surgical procedure. Here we go into the frontal sinus, the frontal recess. Seems to be reasonably widely open. We need to make sure of that as to not cause any iatrogenic frontal sinusitis because of our reconstruction bulk and volume. And as we see here, the frontal recess is widely open. The ethmoid cavity still has some septations which might need to be taken down. So the entire skull base, right from the frontal recess to the sphenoid sinus, can be seen here in one go, from anterior to posterior, along the septum, which is medially, and one can see how even now some bit of flattening has to be done for to make our defect amenable for successful reconstruction. Any half-hearted plugging of defect simply without doing all these steps, without creating enough bare bone, without removing enough mucosa, is bound to fail eventually, as the graft does not get a right surface to stick on and achieve vascularity. No graft, whether it is fascia or free mucosal graft, ever gets attachment onto mucosa. It has to be kept in contact with bare bone, bare cartilage, and it is very important to achieve as much flat bone as possible. It may not be possible to do it completely on all patients, and one must not be overzealous, least to create any complications or more defects, but one should make attempts. Here we can see with the 70-degree endoscope pointing upwards the entire base skull from the frontal to the sphenoid, and this is the sphenoid. We come to the posterior ethmoidal cavity, the anterior ethmoids, and the frontal recess looking upwards. So now one can appreciate the difference of views between the 0-degree scope and the 70-degree scope, which points upwards. The 70-degree scope, we are mandated to use more and more curved instruments so that our field of vision is not blocked. Here we are using a curette to gently fracture and isolate the defect and to make it maybe even slightly larger. Very small defects are hard to close. Sometimes when you have Bernoulli's effect and the meningocele starts coming out and protruding from a small defect, the defect has to be often enlarged slightly to make it possible for the graft, the fat graft, to go inside. one cannot push fat graft into very minuscule openings, and that doesn't work. So here we are clearing some more bone from the frontal recess, trying to make the recess more wide and patent for avoiding any sinusitis post our reconstruction. Working very close to the skull base, one must try to avoid using too much force on the curette or fracture too hard, because that can sometimes also create new defects or CSF bleeds, which is counterproductive. So whenever somebody feels that the force required to push on a cell or on a bony partition is excessive or uncomfortable, it is wiser to resort to drilling using a diamond burr rather than to use a curette. So we here go by a palpatory feel. Whatever is the soft bone, easily fracturable, we do that with the curette because that saves time. But more than that, and as we approach the actual skull base, we would use the curette less and less. So once again, here we are enlarging the ethmoidal cavity even more, trying to take down septations and coagulating the mucosa. Now steps like this might look repetitive and time consuming, but almost the entire part of surgery is basically bed preparation and access in such patients. And once you have made a generous access, you prepared the bed for the grafting or the plugging, then merely plugging or putting your reconstruction grafts here is far simpler than to negotiate them between inadequately prepared sites. Generally, the coagulator is quite safe on the skull base because it doesn't puncture it. We find it safer to use than the microdebrider, which sometimes has the potential to puncture thin bone of skull base. So using the coagulator without any force, even on the ablative mode, should not lead to any skull base penetration. And that is why during this step to ablate tissues, even we can use the ablative mode to clean the mucosa around the defect site. Now that we have removed a lot of mucosa, opened the cells widely, we still need to make the bone more flush, especially for our facial grafts. If we were to just put fat, probably it would be okay. But whenever we are contemplating putting facial grafts, it's very important to flatten the surgical site or the base skull in this patient as much as possible without causing any complication. So we use here a normal diamond burr. We do not advocate a coarse diamond or a cutting burr here. It is normally just a very flat and simple diamond we use for mastoid saucerization. And as we can see here, we take our time slowly to flatten the bone here and trying to reduce the ridges as much as possible, because that would be the most optimal for graft placement and uptake. So we clean here some more mucosa from the base of skull. If we leave this mucosa behind, there is a fair possibility of formation of mucoceles, which would later on give rise to trouble. So just like I said previously, all amount of preparation must be done before we actually come to the step of actual graft placement. So postally in the mucosa, like you see here, we flatten the base of skull even more, and now all the erstwhile partitions that we were seeing before have been taken down. The bone from the entire middle and the posterior ethmoidal cavity looks much more flat and receptive for graft placement. So once most of the flattening of the bone has been done, we take one final attempt to devitalizing the mucosa around the defect, going as far as posteriorly towards the posterior septum to create a good implant bed. The better these steps are performed, the better is the uptake of the graft on this bone. So we can see here that this step has been accomplished nicely. The bone is flat, the mucosa has been devitalized along the septum and the base of skull. Everything is well visible. The sinuses are open. And one can see here the site of the posterior ethmoidal artery. We need not take it down in this patient. Sometimes even both the ethmoidal arteries have to be taken down. This is our navigation probe pointing towards the skull base defect, which sometimes, again, like I said, can get obscured when we have been ablating it or coagulating it a lot. We can see here the depression of the dura, and this is the defect that needs to be closed. So even if in this attempt, if one goes a little overzealous and sometimes makes the defect slightly larger, there seems to be no problem with that. One must not panic, because normally slightly larger defects are much easier to close than very small ones. There are a lot of options to close these defects. We do not normally advocate using of the Haddad or the septal flap for these lesions, because it's a primary case, it's not a recurrence. It's very well visible, and I think fat has a good acceptance rate. We reserve the Haddad flap for very large defects, or in patients where we are handling a recurrence, or in multiple defects. Otherwise, the septal flap causes a lot of morbidity to the patient, and we prefer to avoid. Here we use a straight flat instrument like a septal respiratory or a flap repositor to identify the bone defect. We can see here that we are undermining now the dura. This step also is very important in trying to create a little gap between the dura and the bone. So we are using gently a flat instrument to undermine the dura all around wherever we can. It's a little difficult to do towards the septum, but towards the ethmoidal, towards the fovea and anterior and posteriorly, it is much more easy. Not so much towards the septum. Towards the septum, if one really has to do it, then one has to do a superior septectomy, and that is the only way we can do this step, because the dura gets attached to the crista galli. So here we use some fat harvested from the thigh as the primary graft material. So as we see, we are still working with the 70-degree scope for all this while. It gives us a good vision. So one can use one hand or two hands for it. You can have an assistant hold the endoscope, where you use two instruments and two hands to gently push in the fat inside. If you're comfortable, you can do it with one hand as well. Normally we do not advocate the use of a ballpoint probe, because that always brings the fat out with it. So we always prefer to use a flattish instrument such as this. This is a double bent elevator we use for these kind of patients, and with the 70-degree scope, it gives us a very good angulation of work. We can see that there is no stored conflict of the instruments inside the nasal cavity, and we are able to work rather elegantly with this kind of an angulation. So once again, the fat must be appropriately sized. Very big fat portions cannot be inserted inside this cavity, and also we must not push it very hard. We do not want to shove this fat up the brain. That is not the goal. So it must be done gradually and progressively. Having a little larger than required fat is better than having a smaller one. The smaller fat can get lost. Larger ones, even if it's a little too large, can be later on trimmed while being attached inside the defect. So here we start pushing gently this fat inside the defect. We can place it alongside also the undermined dura as well as inside. The point is to make sort of a seal where some portion of it is inside the intracranial cavity and some portion is outside. We see that it is a little too much, so what we'll do is, while being inside, we'll just cut a sliver of it using the scissors and appropriately size it. Now, post cutting and trimming of the fat, this seems to be very reasonably sized. It is well placed and well tucked inside the defect with the same instrument that we've been working with. It's very good. It doesn't pull the fat back along with it, unlike a ball probe. So slowly and slowly, as we keep doing it, you see that the fat very nicely gets tucked in and seems to be creating a good seal. We do not want to push all of it inside. That's not the point. This fat, of course, would need something on top of it. In this case, we are using a fascia lata from the thigh wound. Now, one must remember that fat cannot be left exposed to the air. It's going to dissolve, and that's not the point. So whenever we use fat for reconstruction, it has to be reinforced and covered with either fascia or a free mucosal graft in the middle, turbinate, or some kind of vascular flap. It cannot be left open. Here we are using a fascia graft to cover the fat, and this fascia graft is larger, so that is why so much effort was done to clear all the bone, the septations, and remove the excess mucosa all around, and to devitalize it where you cannot remove or peel it. Now in this situation, we can use two hands and to adequately spread the fascia over the fat. So this facial graft, as you see, is being placed. Sometimes even this could be slightly larger than usual. We have just placed it with approximation. You can also make actual measurements using a suture sheet, the suture cover, to make approximate measurements to see how big it is. If it is too big, it is obviously difficult to place, and it won't be taken up. If it is too small, again it beats the purpose. The fat must be generously covered with the fascia. Also, the fascia must be in a good contact with a lot of bone surface around the defect for this fascia to be taking up and sticking well. This fascia requires bare bone to adhere. So as we can see here, our sphenoid and our frontal sinuses are well open. There seems to be no problem. The facial graft is well covered, well covering the fat, and well in approximation. And now we just add a layer of tissue glue to cover this. We normally do not recommend the use of tissue glue in between the fat and the fascia, because the fascia needs to come in contact with the fat, needs to come in contact with the bare bone for proper healing and taking up. So we use the glue only at the end of our repair, howsoever layers there would be. Even if there was a vascular flap, then you would have only used the glue over the vascular flap in the end, and only once, and not in between the layers, because then that creates space and sometimes can lead to graft failures. So we just give a few minutes for this tissue glue to act and to make a sort of a soft seal over our defect, over our repair of the fascia, and as we can see here, seems to be reasonably placed. He's not moving and is well spread out. So along the edges we can maybe place a little bit more tissue glue for it to get fully secured in place. And in the end, we just use a large, thin, compressed gel foam sheet to cover this assembly of ours. A gel foam absorbs a lot of water into it, much more than its volume, and can help secure this graft very well. We once again use the same instrument to gently appose the gel foam onto the graft. We prefer to avoid covering the sphenoid os with this gel foam. As we can see here, the frontal sinus, frontal recess, and the sphenoid sinus are completely visible. Our gel foam is only covering the facial graft, which covers the fat, and we can gently use the same instrument to push it up against the base of skull for good apposition, and that seems to be the end of it. We would just put one meningocele pack on the floor. We do not use elastic sheets normally here, and we remove the pack after 48 hours. So as we can see here, some more gel foam comes in the end to secure this on the edge of the septum anteriorly, and one can impregnate this gel foam with either saline or vinegar solution, or sometimes if you want with even an antibiotic soap solution such as gentamicin. So this is the complete closure of the defect and the placement of gel foam, and this is followed by just a meningocele pack.